So this is my presentation. It is on early versus interval postpartum intrauterine device placement. This was a study that was published in JAMA in 2023 by Averbach, Cully, and Hines, and all, and presented by me. So for a little bit of background, short interval pregnancy intervals are less than 18 months between pregnancies, and they are associated with increased risks of maternal and infant mortality and morbidity, such as preterm birth, low birth weight, preeclampsia, among others. IUDs, or intrauterine devices, are a type of LARC, or long-acting contraception, that are one of the most reliable methods of birth control. They are over 99% effective and especially beneficial because of their ease of use. They don't require a lot of follow-up. You don't have to take a pill every day, and so that can really help with the reliability of the form of birth control. However, one of their risks is expulsion, or coming out of the uterus. So because of that, the current standard practice is placing IUDs at 6 weeks postpartum with the goal to reduce this risk of expulsion. However, waiting 6 weeks can have a lot of challenges, especially if you don't have regular health care. It's hard to access health care. There's concern that you'll be lost to follow up and won't have any birth control. And then by 6 weeks, they found that over half of the people have resumed intercourse already, thereby putting them at an increased risk for becoming pregnant again and then having a short interval between their pregnancies and then leading to those other risks. Of note, just under 20% of family medicine physicians regularly insert IUDs, and this is just to show that primary care can play an important role in this discussion, so it's not just always following up with the OB. So the study question was to compare the expulsion rates of IUDs placed between 2 to 4 weeks postpartum with the standard placement timing at 6 to 8 weeks postpartum. The authors hypothesized that complete IUD expulsion rates after early placement was non-inferior to interval placement, or the typical 6 to 8 weeks. They predetermined a percent of 6% as the non-inferiority margin, meaning that if there was a difference of less than 6%, they would say that agreed with their hypothesis. So for the methods, this was a randomized non-inferiority trial, so comparing a different intervention with the current standard. It was done in 4 academic medical centers: University of California in San Diego, University of Illinois at Chicago, University of New Mexico, and the Naval Medical Center in San Diego. It was done between March of 2018 and July of 2021. And these were postpartum patients who had either a vaginal or cesarean birth and indicated that they desired an IUD. They had to be at least 18 years or older, English or Spanish speaking, and within 10 days postpartum. And there were some exclusion criteria, including fibroids or leiomyomata, intrauterine infection that was treated with antibiotics, if they had 4th-degree perineal lacerations, or any medical contraindications to IUD placement. Also, if they desired pregnancy in less than 6 months, if they had a postpartum tubal ligation or another form of birth control, such as IUD placement at the time or right after giving birth in the hospital. So randomization was stratified at each site, and participants were assigned in a 1-to-1 ratio at the early group, that was 2 to 4 weeks or 14 to 28 days, and then the interval group, which is the 6 to 8 weeks or 42 to 56 days. The IUDs were placed by any prenatal clinician, so this could have been the family med doc, an OB, or a resident, NP, and attending. They could have very different providers. And then what happened was all patients had a 6-week postpartum visit. If they were in the early group, they could have their strings checked at this time. And then if they were in the interval group, they would have their IUDs placed at this time. Then all patients had a 6-month study visit. Here's where the clinicians were blinded to the group that the participants were in. And they had a bimanual pelvic and speculum exam, as well as a transvaginal ultrasound to confirm the IUD presence and the position. The IUD was documented as the location and also if there was a need to trim strings. IUD replacement was offered to those with complete or partial expulsion, malposition, or uterine perforation. The participants were also asked to complete a survey at this time that asked about expulsion, malposition, removal, replacement, uterine perforation, as well as their satisfaction. So the goals, the primary outcome was the complete IUD expulsion by 6 months postpartum. They also identified some secondary outcomes such as partial IUD expulsion. They had the IUD removed, any infections, their satisfaction, uterine perforation, pregnancy, and if they were still using the IUD at the 6 months. They found an exploratory outcome, which was malposition, and if they needed to trim the string. Oh, sorry about that. Okay. So here's the participant flow, which just documents how they sorted their participants. So they had 642 who were eligible, and then 404 ended up being randomized, then getting rid of exclusion criteria, as well as people who were lost to follow up. We ended up with 142 in the early group for the primary analysis and 145 in the interval group. And then per protocol, 119 versus 135 in the interval group. This is just demonstrating the characteristics of the different groups. I'm not going to go over every single data, but essentially they showed that the characteristics were similar between the two groups. The majority of participants identified as white, that was about 56.4%. And then the next largest group was Hispanic with 43.3%. A majority had a vaginal birth, and a majority were also multiparous, and that was about 65.6%. Most of the participants chose the 52 milligram levonorgestrel IUD, which is one of the hormonal IUDs. And then the second most popular IUD chosen was the copper or the non-hormonal IUD. The majority of participants were lactating at the time of IUD placement, although rates were slightly higher in the early group versus the interval group, which makes sense just as more people tend to be lactating 2 to 4 weeks as opposed to 6 to 8 weeks after pregnancy. So then for the results, for the primary outcome of complete IUD expulsion at 6 months postpartum, which was defined as no IUD seen in the uterus on transvaginal ultrasound. In the early group, the complete expulsions rates were 3 of the 149, or about 2%. And in the interval group, it was 0 of the 145, or about 0%. They calculated the between group difference to be 2, which was less than their predetermined non-inferiority margin of the 6%. And the secondary outcomes, for the partial IUD expulsion, they found that these occurred in 14 of the group, 11 of the interval group. This was actually found to, with their between group difference, the confidence interval was not significant, so they found that this did not meet the predetermined 6% non-inferiority margin. And then for a bunch of the secondary outcomes, the IUD malposition rates in the early group were 8 out of the 149, or about 5.4%. And then in the interval group, they were 0%. Overall, there were 42 IUD removals. 25 of these were in the early and 17 were in the interval group. There were 3 documented pelvic infections, all of which occurred in the early group. Most participants reported being satisfied or very satisfied. It was about 86.6% in the early group compared with an 80% in the interval group. Most participants claimed that they had their IUDs trimmed at some point, and there were no perforations documented in either group. So for the conclusion, they said that the IUD placement at 2 to 4 weeks postpartum compared to 6 to 8 weeks was non-inferior for complete expulsion, but not for the partial expulsion. And because of this, they said that understanding the risks of IUD expulsion across postpartum period enables patients and clinicians to make informed choices about postpartum IUD placement timing based on the patient's goals and preferences. For the discussion, the strengths of this study included that it was a randomized trial specifically powered to assess IUD expulsion. There were few that were lost to follow-up, and the population was diverse, and IUDs were placed by a variety of clinicians to help generalize the data. However, the rate of complete IUD expulsion was lower than anticipated in both groups, and a greater number of participants than expected didn't have an IUD placed. A small number of expulsions limited the ability to assess for potential risk factors, and the trial was conducted at academic medical centers, which might not make the data generalizable to the general public, who does not always go to an academic medical center for their healthcare. Their per protocol analysis was pretty similar to their primary analysis. Slightly more participants in the early group were satisfied or very satisfied with the IUD use. There were higher rates of expulsion in those with copper IUDs who were lactating and in whom ultrasound was used with placement. None of these were significant results. For pregnancy, which is obviously one of the things we wanted to look at, just because that's the idea behind the contraception, is that 7 pregnancies occurred among all 404 participants. So that includes some of the people who did not end up receiving an IUD. There was 1 in the early group who had a copper IUD and it was found to be partially expelled who became pregnant, and 1 who had a hormonal IUD that was malpositioned in the early group who became pregnant. There were similar percentages of participants for 6 months follow-up. And for the partial expulsion, because there was a small absolute increase in risk of partial expulsion in miscegenation IUDs in the early group, this had an unclear significance though. It did not meet all criteria, however, it did lead to pregnancies, so it was something to consider and think about, especially with discussing possible contraception options with your patients. And the absolute risk differences were small for any expulsion outcome. So because it's small together, does it really matter which one you do one way or the other way? It's about kind of discussing with your patient, which do you care about more, potential higher risk for partial expulsion versus having no contraception earlier on and having a slightly increased risk of becoming pregnant. So I talked through some of that kind of fast, so let me know if you have any questions.